What most people expect is that therapy is going to look like what it does on TV, which is that you sit across from a therapist, you talk about what it is that's ailing you, and then just by virtue of the miracle of sharing, you get better. That's not what works in child and adolescent treatment. What we try to help parents of kids with behavioral disorders to think about, for the best approach, especially for young kids, is to intervene at the point of performance. You train the adults in the child's environment on behavior management strategies. When they see a consistent set of strategies applied, you're more likely to see improvements in behavior from the child.
Being a mom is the toughest job there is, and it doesn't come with instructions. So it's okay if you don't have all the answers. We'll figure it out together. This is Mom Brain with Hilaria Baldwin and Daphne Oz.
My name is Dr. Dave Anderson. I'm a clinical psychologist at a place called the Child Mind Institute. I'm the senior director of the ADHD and Behavior Disorders Center and the senior director of our national programs and outreach. You know.
Concise.
You want me to keep going?
Wait, right. And then you also are a father.
That is true. I'm also a father to a 2.5-year-old son.
Oh, wonderful.
Yeah, Parker. He's a good kiddo.
And a husband.
Right. Also a husband.
Apparently, he's not
Right.
very good
And
at
an expert
I was going to say,
cleaner.
I don't know how much you want me to go into the...
Mom Brain?
I'm an expert breast pump cleaner. That's, I mean, like, I should include a title like Senior Director of Household Duties that make me, soothe my own guilt for not having delivered our child.
It allows you
There's
to
also
spend
that.
yet another day in the home with
Right.
Parker and your
Exactly.
wife.
But my amazing wife, Dylan G., is a neuroscientist at Yale, and she's in clinical psychology there as well. So our whole family is psychologists.
Wow.
Yeah.
What
Your
do you,
son
yeah,
is
I
in for
know.
quite
No.
the road ahead.
He already is highly sensitive to other people's crying. That was the focus of his most recent parent-teacher conference, is that he apparently cries longer than other children who cry over the actual thing that happened. He cries over their crying longer than they were crying about the thing.
For
So much
compassion.
compassion.
Absolutely. So much empathy and compassion. But they think he could probably recover a little quicker. So we're working on some resiliency skills.
Oh,
That's so funny. I
cute.
remember
Right.
those first parent-teacher conferences, and you would, it still happens, because my kids are all
But
like
it's so
3
weird
month-
to
three
go and
minutes
listen
old.
to like a teacher be like, so your 2-year-old.
No,
you know?
usually I have like tears of like, because usually they're saying to you, I mean,
Such
like, a
lovely
lot of
things,
times they're
I
saying
know.
to you, they're like, oh, your child drew this circle and they're so good at making circles. And you're like, yes, genius.
Well, for a psychologist, it's also that sometimes they don't know what you do. So they're starting off and they're like, listen, let us talk to you about your child's social emotional development. And we're like, right, tell us about
Yes.
that.
What
Sounds
is this?
good. So,
Explain.
the reality is I still learn, new
Of course.
things each time because I have my, daddy blinders on.
Oh yeah,
So-
of course. No, it's
Right.
it's completely do as I say, not necessarily as I do.
Right.
I had my kids go to school when they first start during the middle of the day. It's this horrible at their school time of 12 to 2 nap time.
Yep.
2 days a week, which make those days extremely, extremely hard.
Mhm.
And went in and they were saying, Leo seems like he's a little bit tired. Why don't you try to give nap time before or after? And I said, you are so smart. Why don't you come over and you try to do that? Why don't you try to give him nap time at 10 o'clock in the morning? So
Sure.
sometimes there's just advice that is just,
Yesterday, Parker slept for 10 minutes during preschool nap time, woke up because someone else was crying, and then couldn't put himself
cry,
back to
and then
sleep.
continue to cry as you
So-
know.
Oh my goodness.
I tried to take him out to a Mexican dinner, while he's just freaking out on no sleep. It was good times. We had a lot of tortilla chips.
You had a lot of how did you deal with that?
Well, as I think you said earlier, we're fantastic as psychologists at giving out advice, not necessarily on following it. So I accommodated almost every whim told to me in a whining voice, knowing that I was going to pay for it later.
Sure, I'll give you more tortilla chips.
Like, my biggest example is more just the fact that, like, I used to work with adoptive and foster families in Los Angeles, and I would help families on sleep training, especially for kids who, had gone through multiple homes and had never really had a consistent sleep schedule. I have completely failed at sleep training as a parent. I mean, for the last 2 months, he's pretty much in our bed every single night. I'm currently giving him a car every time he sleeps in his bed the whole night. Which
Well,
I
you're
would
worse than
not-
I am. I'm $1.
Right.
I'm like,
That's
I
it.
thought I was a
It's a
total
Matchbox
pushover.
car. Maybe it comes out to a net dollar, but it's,
No, that's
But you
a
had to
solid
actually go out and buy
That's a solid
it.
$6 on Amazon. I know.
Right, exactly. It's the type of behavioral system that most parents would gawk at and say, like, you want me to give him a car every time he sleeps in his bed? And,
Wow.
So-
You do what you got to do. That is,
Yeah,
I feel like, rule of parenting number one is you do what works for your family / do what works for you.
Right.
Okay. Tell people what are some of the most common sort of challenges or young kids. What are you seeing most frequently, and what are you treating most frequently?
I mean, the thing is, because we have kind of clinical centers at the Child Mind Institute, so because we have an ADHD and behavior disorders center, an anxiety disorders center, mood disorders center, and a learning development center, most of the referrals that come to me are kids with behavioral issues.
Mhm.
So most of them are kids who are experiencing, prolonged tantrums, many tantrums a day. They're yelling and screaming at their parents. They're throwing things. If we're talking about the young age range, like 3 to 7, it tends to be just that anytime, they're being told no, or anytime the schedule changes, or anytime they're having a preferred play toy or screen taken away, or if there's any time pressure and everybody's kind of stressed, like getting out for school in the morning with multiple kids.
Mhm.
Most of the referrals that I get tend to be kind of in that range, at least when they're younger kids. And it's just parents at their wits' end trying to figure out how to deal with these behaviors and still get the family out of the house or make it so that the other children in the house aren't taking their example from the one who's throwing the tantrum.
Completely.
What do you attribute those behaviors to? Is it something that's just biological? Is it something that is a trauma that happened to them? Is it just that the parenting can be better? Is it all of them in different situations?
It's a great softball question. that's like my first 2 slides
We
in
butter
any
you up on
presentation
Matchbox, and then
on
we
behavior disorders.
dive
Right, exactly.
right in.
Get me talking about my kid and just loosen me up. No, it's more that when we look at behavior disorders, or at least the emergence of the categories of ADHD or say oppositional defiant disorder, some of it is genetic. Like ADHD is thought to be, based on the research, very genetically loaded. You're likely to have a parent or a first-degree relative who has ADHD symptoms if you yourself have ADHD symptoms. And so we expect that that's going to emerge early on in development. A kid who can't focus for as long as their peers, highly distractible. For the kids with hyperactive impulsive symptoms, they're always getting into stuff that is off limits, not
Mhm.
because they have any malicious intent, but just because they're not interested in anything boring or repetitive, anything that requires a lot of effort, those kinds of things. So we look at that as something that emerges early on. The issue is naturally the way that we respond to it is that we think that maybe they're doing it intentionally, or we try to discipline them or remove them from the particular thing, or we reprimand them or give them, a kind of talking to.
And those things don't work.
Uh, Everything I just listed can work at some level, but it needs to be tweaked and also included in context with a number of other strategies. And then the thing is, there are also environmentally kind of derived, behavior problems, where we know that like certain factors, like a kid with a reactive temperament, so a kid who kind of reacts strongly to all kinds of different things early on in life, or who can't be soothed effectively by a parent, coupled with, say, harsh and inconsistent parenting. So parents who come in and say, look, kids should be, seen and not heard. They should be listening to me. I come down hard whenever I see them misbehaving. I make sure that they understand that I'm the boss. Like those kinds of, parenting styles can lead over time to huge power struggles. Because the belief or the underlying belief is the loudest voice in the room is the one that should be
Mhm.
listened to.
Mhm.
And, when you see that modeled for a kid, most kids try to be the loudest voice back.
Right.
At the Child Mind Institute, what do you do to help ameliorate some of those sort of tendencies and help those
Right.
families find their way back to like a place of normalcy in their everyday life and how they can cope with those?
I mean, for young
Problems.
kids, therapeutic approaches are sort of counterintuitive. Like what most people expect is that therapy is going to look like what it does on TV, which is that you sit across from a therapist,
Mhm.
you talk about what it is that's ailing you, and then just by virtue of the miracle of sharing, you get better. That kind of thing.
Mhm.
That's not what works in child and adolescent treatment. So what we try to help parents of kids with behavioral disorders to think about, or parents who are just experiencing challenging behaviors. So the best approach, especially for young kids, is to intervene at the point of performance. You train the adults in the child's environment on behavior management strategies. And then if you train the adults, say at home, their parents or caregivers, and you train the people who are working with them at school, you train, their baseball coaches or whomever else you can get in contact with, when they see a consistent set of strategies applied, you're more likely to see improvements in behavior from the child. It's not about how many talks you give about the behavior. The reality is if you were able to change most children with behavioral issues, their behavior with talking to, you wouldn't need a therapist because most parents just do that kind of naturally.
Right.
Similarly, if yelling or being coercive worked, again, you wouldn't need the extra support. But since that stuff doesn't really work for any human, what we try to do is, at least in behavioral therapy, help parents and teachers to understand kind of a balance of strategies that nurture a child and strategies that provide structure. So we try to make expectations more clear. We try to make sure that parents have a range of strategies for reinforcing positive behavior proactively, knowing what they're looking for and paying attention to it, which is against all of our nature. Most of us are negative behavior detectors, not ones who just walk into a room and say, "You're both looking at me so attentively and making such great eye contact. And I really love the questions you've asked me so far because they're right in my wheelhouse." Like, we don't normally create great specific praise right off the bat. We wait for something to go wrong and then we think we have to intervene. So we train parents to be more proactive in intervening when good things are happening, as opposed to only being reactive when bad things are happening. Then we still train strategies around how to give effective commands, ignore minor misbehavior, and administer punishment in a way that's behaviorally informed.
That's super interesting, actually, because I'm just sitting here thinking about, between us, we have 7 children under 5.
Right.
For mine specifically, I have girl, boy, girl. And I think it's really interesting, each of my children have things that they excel at and things that they struggle with.
Yeah.
I'm trying to think of the last time that I proactively with my daughter, I do this because I think probably some parent teacher conference, they were like, she writes her letters so nicely or whatever. So I see her doing her workbooks and she's really focused on them, I'll say, "I love how hard you're working," or "I love that you're putting so much time into this, and I'm excited to get to do blah with you after you're finished," or whatever. But with my son, I do, like, for athletics and things, I'll say, "Oh, I love that," he loves basketball. My son's like beyond obsessed with all ball sports. And we got him this little arcade basketball game for Christmas. And he will sit there and literally shoot this ball 50 times. But he's one of those people who cannot stand imperfection. Like, he literally just turned 3. It's close to your heart. I know. I know that hits you close. And this is a game for 7-year-olds, 10-year-olds. He probably makes 6 out of every 10 shots. And every time he doesn't make a shot,
That's
he's
still
like,
a great shooting percentage for the NBA right there.
I know. I'm trying to get some money out of it.
You can make a career on that.
Right. No, that's what I mean is, as an adult, you're like, holy crap, this child is shooting and shooting and he's good. But he gets so frustrated with himself when he doesn't make the shot. Yep. And so I've tried to be like, "Oh, I love that you did it again. I love that you made it in," or not that you made it in, but I love that you kept practicing and then you made it in.
Right.
But other than that, I'm trying to think of the last time I would have said, "Oh, I love that you're sitting quietly and playing so nicely," or "I love that you are being so patient with your sister." He's got a 1-year-old sister who loves to, like, beat him and just sort of pat him not beat him, pat him on the head, but it's a little harsh, and it's and that's a really good point, is how do we pay attention as adults to the behaviors we want to see more of and attribute good things to those and not focus on the negative so much.
And I'm going to do a mini consult on both his basketball behavior and then the other stuff really quickly.
Are you an agent also?
I mean, what you highlighted was that, like, he's perfectionistic about his basketball behavior, which also undermines the impact of a parent's praise. Because if
it has nothing to do with me. He doesn't care about my approval at all.
And the reality is that's also the functions of behavior. Like, what we know is that, the functions of behavior, there are 4 of them. So you can have an internal sensory experience. Like, in this case, that's his actual reward. It's not your attention. Although your attention may be a secondary, kind of motivator for the behavior. But for him, it's the pleasure that comes along with making a shot, the sense of accomplishment, and the fact that he wants that feeling more. The other motivators can be escape, which means, like, if for some reason the basketball game, every time he, missed a shot, it, like, sounded like a fire alarm, you'd see him running away from it. There can be attention, which is the fact that his mom is standing there watching him and he really loves that. Or a tangible reward. Like, if you said, "I'll get you pizza if you make 7 out of 10 shots." All of those things can be motivators. So the thing is, you're experiencing the same thing that a parent experiences watching their kid play on an iPad. It has nothing to do with your attention. They don't want to escape, and the iPad's already tangible. Reality is, it's already rewarding behavior. They may do it forever, but you're trying to undermine his perfectionism. So what you want to focus on is how you normalize the behavior in question and make him think that that might actually be an objective, and then get him congratulating himself at the same level that you are. And I don't actually normally have to consult with parents on getting their kid to lower the bar. Usually it's parents lowering the bar that I have to consult on. But it's like, show him Steph Curry. Show him that the best 3-point shooters in the NBA, Clay and Steph on the Golden State Warriors, that they are unable to make more than, say, I don't actually know their percentage offhand, but I'm just going to go with like 50% of their shots. Like, Clay made 10 right in the first quarter recently, so maybe they're anomalies. But if the best 3-point shooters in the world only have this shooting percentage, we got to shoot for that. Like that's our job in terms of managing our expectations. So you show him those videos, and by that you connect with him on his interest, and then you can, have a praise that may be more relevant for him. Like right now, you just shot a better shooting percentage than Steph Curry. Like I am so impressed with the shots that you
Mm,
made, rather than just being each shot. You're at least aligning on what the behavior of focus is.
right.
Now, to your point about reinforcing, the thing is, with most kids, it's really easy to reinforce around things that are clear, signs of achievement within society, sports achievement, academic achievement, those types of things. It's harder for any adult to think of what they want in terms of social shaping or behaviors.
Mhm.
It's like, you sit down at the dinner table and you just expect that the kids are going to, by osmosis, figure out through modeling what they're supposed to do.
Well, because that's what our parents told us. Like, oh, we just sat at dinner and everyone ate together and everyone was like, I honestly think back to when
Yeah.
our parents were raising us or when their parents were raising them.
Yeah.
There were no iPads. There weren't even there were no cell phones, obviously. There were no distractions of that kind. And yet somehow they made it on long car trips and where all the places we go where screen time feels inevitable and modern distractions feel inevitable. So, yes, we expect them to learn by osmosis how to behave and how to be good, quote unquote.
Right. But we also adapt to whatever environment or time we are born in. It's absolutely true. So the balances of work and play, the fact that digital means of amusement are available, whether parents, parented without amusements at the table in previous generations, this is the reality of this generation. There are screens. You do have TVs. Many families have them in every single room. So the question is how you set boundaries around them and how you make it so that you still get the behaviors that you're looking for. And for most parents, it's that they're proactively educating the kids on what behaviors they'd like to see at the dinner table. So, from the moment they start eating with family, it is, I want you to know that as a family, we all use our fork and we try to get all the food into our mouths as like, young toddlers. And then as they start getting more and more of the food into their mouth and their face starts to look less like, as target practice, you keep reinforcing that particular behavior. But we try to get families to think about what behavior they're focused on, especially with young kids at dinner. Is it eating with utensil? Is it giving other people the chance to talk? Is it, drinking a little bit of water during the meal? Or is it saying thank you to the chef? I've seen families where the meal is a complete mess in terms of manners, but everyone is thanking the parent who cooked the meal,
Mm-hmm.
for cooking the meal.
Mm-hmm.
So it just depends on what a family wants to focus on. And you don't get humans to start showing a behavior by just criticizing them after
Right.
the fact. You know,
We see, I think so many times people, not just through worry, but we look at our kids, we're obsessed with milestones. We, a- any amount of crying sometimes can feel overwhelming. Any amount of hitting, any
Mhm.
amount of throwing things, just any kind of bad behavior. When is it a problem and when do we just have to be like, you know what, they're just kids? Now, when we're at home and when our listeners are at home, I mean, obviously we shouldn't necessarily self-diagnose our kids, but it's our job to watch them every single day and make sure that they're
Mhm.
going on a certain path. What are certain things to look out for? When do we just need to take a deep breath and just say they're kids and they're going to grow out of it?
So I'll throw out a point first, and that is that therapists don't bite. So this idea that a parent has to be as informed as a clinician about whether or not there's a problem is
Mhm.
something we'd love to do away with. Just because we want, in general, across the entire field, we want to increase access to mental health services and decrease the stigma that comes along with seeking them. Because I'd much rather that a parent have access to a clinician and say, I'm wondering if this is actually a problem,
Mhm.
then do what the research shows parents do, which is notice a problem and then wait 2 to 4 years before they actually consult a professional on it. And the reason for this is that we want to make sure that consulting with mental health professionals is about as mundane or run of the mill as consulting with a pediatrician. We want people to realize that that's kind of what's going on. But I think within uh, many of the kind of media focused discussions, there's this sense that what clinicians want to do is diagnose as many people as possible and lure them into treatment. And that's really not why anybody gets
Which
into this
often
field.
means medication.
I mean, it could. I'm a psychologist. I can't prescribe medication.
Mhm.
So I've got to have some other motivation other
Mhm.
than wanting to get kids to be medicated. I think that that's commonly the ascribed kind of, motivation for a psychiatrist. But I don't meet psychiatrists who have a lack of patience asking for treatment.
Right.
So in that sense, I think there's this idea that there must be these psychiatrists who don't have any patients coming in. The only way that they will is if they convince people to medicate themselves. We don't really have a problem with whether or not people are wanting to utilize psychiatric medications. It's more about how informed we are about them. So talking about how parents can think for kids, there are no objective tests of DSM diagnoses. So all of
I'm
our
sorry, DSM.
Yeah, what is
sorry, there are no.
I know we're really smart.
Right.
but, like,
There
could you
are
just-
exactly. I realize I should not necessarily just throw out abbreviations. It's more that for all psychiatric diagnoses, there are not blood tests for them. We don't have brain tests for them.
Right.
The science isn't there yet.
Right.
So the reality is, if you're going to be diagnosed with something, it comes from meeting with an informed clinician and then helping to give them as much information as possible about your child, and then having them make a determination as to whether or not your child's symptoms fit into a clinically severe range or a relevant category of symptoms
Mhm.
that we have, within our kind of diagnostic manual. Now, when we talk about how to make a diagnosis, these are all behavioral symptoms. So you have a list of symptoms, and what you're assessing is an abbreviation called FIDI, which I will define.
Mhm.
Frequency, intensity, duration, and impairment.
Okay.
You're trying to figure out how frequently the behavior is occurring, how intense it is when it does occur, how long it's been happening, and how impairing it is to the child at home, at school, or with peers.
Mhm.
And you don't make a diagnosis unless you see all four of those categories occurring. So even though these symptoms are often publicized as, things that happen to everyone, like for example, with depression, people feel irritable. That happens. Or people feel sad. Similarly, with ADHD, people feel distractible, or sometimes they do feel like they need to move around and they don't want to stay in their seat. What you're taking is normal human behavior and trying to say, when does it hit an extreme?
Mhm.
When is it an extreme where this person's mental anguish around this is too much, or it's causing them so much impairment in settings where we want them to function that they really need treatment to bring them back into the normal range?
Mhm.
That's all psychiatric diagnosis is. How do we figure out if someone falls into that range where it's really A, impairing their functioning now, and B, likely to have a really negative effect on their development, and how do we bring them back in the normal range? At the same time, because it's not just a yes or no, you have this or you don't, but rather a spectrum of human behavior, if someone has even a mild level of this, the same intervention should work to bring them back into kind of the normative range. So if a parent is seeing behavior at home, the same interventions that would work for a kid who has clinically severe behavioral difficulties likely work even for mild behavioral problems, which is one of the reasons why you have, for example, in the field, Alan Kasdan, who's one of the creators of parent management training, one of the major behavioral parent training approaches, has one book called The Kasdan Method for Parenting the Defiant Child, which is much more oriented toward, clinical treatment of kids with behavior disorders. He also has another book called The Everyday Parenting Toolkit, about 100 pages shorter, sounds very positive. It's the exact same material. It's just 100
Wow.
pages shorter and oriented toward normally developing kids because the interventions work similarly no matter what behavioral issues you're seeing.
Uh-huh.
It's just that it's marketed to a different audience that doesn't want to label their kid as defiant in the bookstore
Mhm.
Right.
or on Amazon.
So in theory, the strategies. Let me ask a more maybe generic but
Yeah.
inflammatory question: could all children benefit from the treatment or the therapies that you use?
That is the focus of some of these treatments. So Triple P, which is the positive parenting program, actually has levels where it's population-based, then it's prevention, and then it's intervention. So the idea is that there's a kind of light version that every single parent could get that would benefit every parent related to behavior
Mhm.
management. Then there's also a prevention version where you take, for example, kids who've been through multiple foster homes or families who are reunited after being separated for abuse or something like
Yeah.
that, and you give these strategies, although that could be also intervention too. And then there's also the kids who have clinically relevant difficulty where you intervene. And the idea is that you've got kind of small, medium, and large doses of intervention depending on the severity of the issues that you're dealing with. But that's one of the reasons why we do so much parent outreach and educator outreach is we're trying to make sure that at a baseline, most parents have at least some awareness of what works for human behavior. The other thing that we talk about with these strategies is they work for all humans. Like in general, when we look across couples therapy, when we look across how you consult with bosses and their employees and parents and their children, the same strategies for shaping human behavior apply. Make your
Mm.
expectations clear, specific, and measurable up front. Make sure that you reinforce positive behavior at a higher ratio than you give attention to negative behavior. Ignore minor stuff you don't need to necessarily, concern yourself with, and utilize consequences consistently, sparingly, and for brief periods of time so as to correct the behaviors in question.
Can you
That stuff
repeat
works for
all of
everybody.
that again?
Right.
That was very impressive. Four very useful tips. And
Right.
I'm sitting here thinking about every relationship I have, and it would be every single one of them would be healthier if I was more consistent, more willing to let small things slide, more able. What were the other two that I'm missing?
Right.
More
So it's more consistent with your expectations
Yes,
up front,
expectations.
with specific and measurable
So
expectations,
that's
not
tough.
just be better.
Yeah,
You know.
well, exactly, because I think that's in your frustration with, like, if you have a kid who throws tantrums all the time,
Right.
it's hard for you to even get clear in your own brain as the parent what would look better to me, like what is progress in the right direction, and
Right.
how do you define that in sort of measurable quantities?
Now you're talking like a behaviorist.
See,
I mean, this is
we just need you here for a few more
This-
hours,
right.
and then we'll be ready.
Soon you're going to know all of his letters that he's putting together.
Right, exactly.
PPD.
You're
All I
like,
need is
I
an
get it.
S.
I know.
soon all of
Triple
these things.
P.
By the way, I think you threw out PPD there,
I sure
which I
did.
believe is a
Is it a real
medical
thing?
test for tuberculosis. But anyway, no, the thing is, when we talk about kind of setting up specific expectations or working with child behavior, the formula, for example, for that treatment is that we get parents spending more quality time with their child in which they are not trying to give a ton of directions or criticize their behavior or correct them. Then we help parents to make their expectations for, the day or certain times of day clear. We try to help them to build up their skills at catching the child being good more often. Exactly what you're saying. Ignore the small things and then engage in a consequence consistently when really huge misbehavior occurs, like hitting a sibling or, in some families it might be using swear words, or in others it might be jumping on the furniture. But we get parents to focus in on the behaviors that are really in need of punishment, not just punishing because the child steps, out of bounds at all,
Right.
and trying to figure out how we can keep children in zones in the sense of, most of the day we want to be at this baseline of trying to catch a child being good and reinforcing good behavior. Then for a part of the day, we want to be in that place we grit our teeth, ignore and try to not pay attention to the behavior, even as we might be trying to redirect the child or give them appropriate choices. Then there might be a portion of the day where we're in timeout, or we've removed some privileges, or, we've moved bedtime up or something like that.
Yeah. No, I mean, I went to go see Dr. Anderson. I mean, of course, my kids are kids. Mostly just because I'm so fascinated with his parenting methods. So I've been able
Yeah,
to pick his brain.
You make me sound like I'm some sort of wizard. I don't have parenting methods.
You are
These
a
are-
wizard.
These are just research-based parenting strategies
We are,
that
okay, you are
train.
a wizard. We are
Right.
the desperate mothers of 7 children, 5 and under.
Right.
Any kind of glimmer of hope or wisdom, even somebody just saying
Right.
to us, "It's going to be okay."
Right.
It's just like the clouds part, the angels are coming out, they're singing, it's great. I mean, I have to say one of the, and I did find that I naturally did this, but it did help me to do it even more, is just to constantly, notice when they're doing something that's really great. And I have like my bottom line things. I want things to be kind. I meaning nonviolent, respectful. I want them to be giving.
Right.
I want them to be good sharers. I know that people say that little kids can't share, but you know what? Actually, my kids are really good sharers. They really are. I want them to be good listeners. I have a few things that I really hope for. And then when they do stuff that's kind of naughty, like they're going to spill their water, or they're going to throw something, maybe I'll, redirect them, or we'll kind of ignore it, or maybe let's not do that again. Today Rafa drew on the wall.
Right.
I didn't like that. Then I had to take a little eraser
That
and
wasn't
erase.
in your value statement of
wasn't in my
giving and
value
sharing and
statement.
holding and loving.
That wasn't in my value
Right.
statement, but I didn't need
Yeah.
to make a big deal about it.
Right.
It was something that was going to be okay in the end, and something that I think that every parent, that ends up dealing with. Now, people with ADHD and ADD and all these different things that are
Wait,
very.
Hilaria, I
Oh,
want to go
sorry,
back to
sorry.
one of the
Okay,
things
go
you
back,
said
go
because
back.
I gotta praise you for
Oh,
that.
thanks.
It's that it's hard for most busy parents to have even the moment to reflect on what you just summarized, which is the biggest values you have for your kids. And what we try to do with most parents is once you have those kind of like 5,000-foot values, like you want your kids to be good at sharing and great listeners, but at the same time, they're really young and they don't get a lot of these social skills. What we try to get down to specifics with any parent is what does that look like in practice? What would that look like for a 3-year-old, in a play situation where they're being tested with a couple siblings? How would you know that they're listening? How would you know that they're sharing? What we're trying to do is make it so that rather than have a parent be in this mindset of, I am waiting for someone to chuck a toy at someone else or draw on the wall, and then that is the moment where I will intervene. But for the meantime, maybe I'll check my phone for a second because they're actually playing nicely, which, no judgment, everybody's doing. But it's more that we want it to instead be a mindset of, okay, remember my values. I know some kid's going to draw on the wall at some point, and I'm going to have to intervene. All right, put that aside for a sec. Who's sharing right now? Who's listening to somebody developmentally appropriate level? And the more you can catch those things, the more, A, your kids start to do those behaviors more, and B, they start to expect that mommy's speech isn't always corrective.
Right.
That it won't always be, you drew on the wall, give me the crayons.
And then also just emotionally for myself, by already having that conversation of like, I know somebody's going to draw on the walls. I know that there's going to be hitting. I know that this stuff is going to happen. It helps me to not flip out.
Yeah.
Right.
Yeah.
Because if I have such a high expectation, then I am so wound tight and then I will explode. Whereas I'm like, okay, that I look over and I'm like, of course that's happening now. This and this and this is happening. And of course, Rafa just took a pencil and just like scribbled all over the wall really, really quickly. And it's just a moment of like, I need to take a little laugh for myself and then I need to be firm with him. Then he always says to me, you don't like me? And I'm like, of course I like you. I like you. I love you. I just would like if you drew on a piece of paper. That's the way it is. And keeping it really simple. And I don't need to yell at him about it. But
I mean, so much of this sounds like it actually is parent training, not child training, which is really interesting. He just gave me the bingo sign. I
just gave you the double point fingers right there. Yeah, exactly.
He just gave me the Wild West gun symbol. Yeah, no, that is. Again, we keep coming back to this, funnily enough, in the conversations we've had this week, or what will have been many weeks for you guys listening to the podcast we've recorded, it is thinking about motherhood. Before I became a mother was about me, and motherhood now that I'm actually a mother is about my children. And in so many ways, the strategies that we're talking about in terms of raising happy, confident kids, actually, we had Dr. Tova Klein on the show recently, and she said, your job as a parent is not to make your kids happy. You cannot make your kids happy. Humans have to make themselves happy. And actually, kids of all humans are really good at making themselves happy for the most part. But, if you're looking to raise confident and at least well-adjusted and adaptable kids, it's pretty much dependent on how you respond to different situations because they're testing you, they're testing their environment, they're testing themselves, and your ability to moderate and kind of regulate your response seems to be as important, if not more than you giving them good strategies too.
Which, I mean, the thing is, the reason why these interventions are called behavioral parent training, which is hard for some parents because they think my child's the one throwing the tantrum.
Right.
Why are we training me in this? And we often say to parents, it's not your fault. You're just the solution. But the thing is, with the parental emotion regulation piece as well, that's another thing that shows up over and over. In the sense that if you can't keep yourself calm in difficult situations, this also goes hand in hand with praise. It's that what we know about child development is that if kids get positive feedback for the good behaviors that they're engaging in, at the same time they know where the guardrails are, and they watch a parent model resilience and also let them, deal with discomfort a little bit or sit with discomfort. So in the sense that if a parent knows that their child is uncomfortable, but it's not something they can change for them, or it's something they're just going to have to weather, that can be a great message to a kid. Look, you're talented in all these other areas. You hear me telling you about this. This is something that's just going to be harder for you.
Yeah.
And, I wish that I could make it go away, but I can't. But I'm going to be right here next to you as you go through it. That becomes their coping language with themselves as adults. They remember where their areas of strength are because we're not utilizing praise just to build up their self-esteem as kind of a fake house of cards. We're really trying to meet kids where they're at and praise each of their kind of, next jumps in development. And then we're also trying to say, at the same time, you're not always going to be good at everything. You're not always going to find success in each thing you try. And that's why your self-talk has to be, I have been successful in other ways. I could likely be successful again, and I can sit with this, and this is going to be okay. But that emotional coping piece coupled with the feedback piece is huge for raising psychologically healthy adults.
It's really bringing them into a place of reality,
Yeah.
which I think is so important. I mean, we all want our children to have great imaginations and, dream big and all that kind of stuff. But then, giving them a dose of reality and simply just talking to them
Absolutely.
and creating realistic expectations is extremely important. Now, ADHD and ADD are things that are very widely thrown around. It means inability to sit still and focus. Yes. Bring us through exactly what it means.
Right. So it's ADHD. So first we can start with that. ADD hasn't existed since 1994. It's still talked about in that way in society, partly because ADD has less stigma associated with it. The thought is that without the H, you're just inattentive. Maybe you're just a spacey kid. You're not as hyperactive or impulsive. But as of 1994, it became ADHD with different subtypes. As of 2013, it became ADHD with different presentations. We'll talk about what that means. There's two clusters of symptoms in ADHD: inattentive symptoms and hyperactive impulsive symptoms. And the thing is, you can be diagnosed with ADHD inattentive presentation, meaning you have 6 of 9 symptoms on the inattentive axis. You can be diagnosed with ADHD hyperactive impulsive presentation.
Wait, I should tell you one thing,
right, there you
which
go.
is that the people listening to this podcast have slept like 3 hours in the last 3 days. So just like take it 10
all right,
nights.
all right.
This is going to be the podcast that there's like
Just take us back to first year.
This is going to be the most amount of like rewinds and re-listen in any of our podcasts.
it will be so worthwhile.
Yes, no, definitely.
So here, I'll throw this out.
Yes.
If you want more information on the diagnostic criteria related to ADHD, you should go to childmind.org or understood.org or Attitude, which is another kind of ADHD-focused website. But the thing is, for the symptoms, there's inattentive symptoms, there's hyperactive impulsive symptoms, and you can have a cluster of inattentive symptoms or a cluster of hyperactive impulsive symptoms. The basic flagship symptoms are difficulty focusing, difficulty with distractibility, difficulty organizing yourself, and then difficulty staying in your seat, not blurting things out in class, or interrupting adults.
Mm-hmm.
Now, all of those can be normal behaviors of childhood. The thing is...
Sounds like toddlers.
Right. Well, one of the reasons why we're so cautious in diagnosing ADHD amongst younger children, one of the reasons why behavioral parent training approaches like we've been discussing are the frontline recommended treatment by the CDC and other organizations, is because at that age, it still may be coming from a number of different causes. One of the things we always talk about with ADHD is that inattention or difficulty focusing can be a symptom of ADHD, can be a symptom of depression, it can be a symptom of post-traumatic stress, it can be associated with a learning problem in a certain area, speech language difficulties, head trauma, a couple different medical explanations. So diagnosticians need to both rule in a particular disorder, at the same time that they're ruling out everything else as an explanation for the symptoms. That is a massively complex problem to try to confront, which is the reason why we don't really want anyone to try to solve it by Googling at 2 o'clock in the morning.
Well, also because you go down the Google wormhole and you can diagnose anyone with anything. And I think, it's interesting because on the one hand, as a parent and a student and someone who's endlessly curious, I do that because it makes me in some ways feel more empowered to have access to information.
Sure.
But on the other, it's hugely confusing because to your point, it can say, are you tired? Do you feel like maybe you could use some more time to yourself? Do you then you must, have PPD or whatever. It's like whatever.
We're still in a non-mental health abbreviation.
I have no idea what that even means. But it's complicated. And I think on the one hand, I think diagnoses are comforting to people because then you have a path forward and then you can start to pursue a strategy of treatment. But I also think, to your point, it's equally rewarding and valuable to rule things out as it is to rule things in, and that's what it sounds like. You're very, very cautiously and very carefully. The diagnostician is actually putting the puzzle together, because that's what really, it's sort of like worms in my head sometimes, because as we're humans, we like boxes, we like categories, we like people to put things safely in different little categories so we can understand them, but the human brain is so complex and so it develops so quickly and it changes so dramatically. I love the idea of like brain plasticity and that you're constantly evolving, and that a child who, they don't like to talk about cures, quote unquote, because with the brain, it's really hard to know what is cured and what is ameliorated, or what is, you have strategies that are better now. But you can have a child who struggled with so many things at 4, who at 10 or 15 presents none of those things. Do you see a lot of that? Do you see a lot of like
growing out of it?
No. I think we caution parents against the growing out of it kind of comforting thought. Again, it goes back to see us. Come and see a mental health professional, and let's talk about whether or not it's something that could require some support. Because there are 3 options here. One is that the child could grow out of it.
Yeah.
Another is that, a child with some intervention might grow out of it faster, as in like we can accelerate that process.
Right.
Or there's really something wrong that they will not grow out of, and that only has negative developmental consequences for that person. So we're still trying to make it so that screening is something that is not a dirty word.
Yeah.
That if you go for a mental health screening, it becomes something where it's just like getting an eye screening at school, or, getting checked out of the pediatrician. We'd love for people to think about it that way. I think the issue with mental health is that if you go online and you type in, why doesn't my child see the faces on the people who are performing in my daughter's ballet performance, someone might, write, like, your child probably needs glasses. Like, this is an issue. Whereas if you go on and say, why can't my child focus? You're going to get 3 websites with great scientifically supported information, and 4 websites that inform you that the psychopharmaceutical, machine is attempting to medicate your child and convince them of, the fact that their beautiful childhood has gone up in smoke, and, now they've got something really terrible. And we're really trying to kind of fight that particular stigma. That, that's what's actually going on in this situation. We want people to ask those questions. If their child's focus is developmentally appropriate, if they're focusing as well as their peers, to send a clinician in to be able to say, look, let's look at all the ways that these symptoms could be caused, and to know that one of the conclusions that's possible there is for the clinician to say your child's completely normal.
Right.
I'm sure something that you hear sometimes as well is, do they just need a different kind of style? Are we trying to create all of our children to be like lemmings? You must sit down, you must do this, you must do this. I mean, I'm somebody, I hate sitting still.
Right.
I do not like going to movies. I do not watch TV. I want to be running and jumping, and I've been like that since I was younger. That being said, I could make myself, I'm sitting down here right now, right? I'm not fidgeting. I'm not,
You've not been doing yoga while we've been talking.
I am not upside down, guys. I am right side up. That being said, I once everything's over, I am somebody who I will be excited to stand up. If people, but like afterwards, people will say, "Oh, would you like to sit down?" Like, absolutely not in a million years.
Right.
And so I like my husband, for example, loves to sit down. He loves to watch movies. He doesn't want to get up a lot of times. And we are the yin and the yang. And you could say that maybe he was the kind of person who could really, really, really focus in class. And I was somebody who had to make myself focus in class, but I would prefer to be doing something else. How much of it as well, as the kids who don't have as great, impulse control, that how much of it is just that they're just different, and is that something, are we saying that there's something quote unquote wrong with people when they're just really not conforming to society?
So it's funny that earlier we were talking about the idea that previous generations talk about how they just told kids to sit and have great manners. And right there, that's the kind of parenting philosophy of today that's at odds with that, which is this idea that like maybe the objective isn't that our kids sit as, amazing little mini adults at the table, but maybe the idea is that we're putting them into too many little cookie cutter boxes. But when you think about what we're trying to do in mental health, it is not to stigmatize anybody or over pathologize anybody. It's really to look at that last, category of impairment. It's that we agree that humans are, incredibly varied in terms of their presentation, and we don't want to make anyone feel bad for who they are. And the thing is, if the fact that you wanted to move around, which is true of, lots of toddlers and lots of kids in elementary school grades, that they benefit from movement and that they should be moving around, we want to figure out if that's, something that looks like your peers. So if we go in and do a classroom observation when you were 5 years old and, you had 3 kids you were playing with at recess and maybe stood at the side of your desk a little bit or asked the teacher if you could take a few more water fountain breaks, that might not mean that there's any particular clinically significant thing going on. It's just that your kid needs to move a little bit more. But if, on the other hand, the teacher said she misses half of every lesson because she's constantly doing cartwheels in the hall and tells us that unless she's inverted during reading, there's no way that she's going to be able to focus.
I could picture this.
I had my moments.
Right. Well, that's the whole thing is we might say, like at first with a young kid, let's give you some strategies that'll help you to shape Hilaria's behavior while she's, in your classroom so that maybe she could be right side up during reading, but you give her some inversion breaks, whenever she's completed her reading assignment. Or we might say, like, if she asks to take a bathroom break in the middle of math, your answer could be, I loved what you did in your math assignment yesterday. I need you to do 2 more problems, and then you can do 5 cartwheels in the hallway, 2 for 5. And we'll make a deal. And then you might sit there and say, well, I do like my teacher, and I like being told that I did the right thing, so I'll do my 2 problems and then get my reward of my cartwheels.
The motivation.
I know.
Right.
What do you make of the role of diet, if at all, in all of this?
So what we generally say with diet, physical exercise, and sleep are that for all humans, they are good for mental health, but they are not a treatment for any mental health disorder. So eating healthily, sleeping an appropriate amount of time each night, decreasing the use of screens within an hour of bedtime, those kinds of things, and then getting physical exercise, all are really helpful for mental health. It's one of the reasons why adults spend almost their entire adult lives trying to get enough of any of the 3 of those.
Right.
So we know that helps us. At the same time, for example, for ADHD, there is no dietary change that has shown scientific evidence of treating ADHD. So in that sense, we still go back to, look, have a healthy diet, exercise, and sleep, but don't put your hopes in a gluten-free diet for treating the symptoms of ADHD.
What excites you about what you get to do? What makes you happiest when you see parents and families come to you?
Well, there's 2 answers to that. One is I was raised by a psychologist and a psychiatrist. So the thing is, I feel like it's in my blood to be thinking about humans in this way. Like my family thinks about what's going on for people, what's causing them pain, what are the interpersonal dynamics going on in this situation, and how do we help them? How do we help make things better? So I feel like I grew up with that in my blood. And that's really what is rewarding for me. I think as I've moved forward in my career, the extra reward that I've gotten from kind of the micro of kind of solving situations or helping people to problem solve around situations that are causing them some level of anguish is the ability to then communicate to larger audiences about how to do those on kind of a larger scale or how to problem solve on a larger scale. So I've gotten really passionate about making sure that if there is something we know in science, that if people aren't reading the article in their ivory tower, they're not aware of it, I'd love to try to be as much of a mouthpiece as I can for getting that out there. Like to your audience and the moms who've had 3 hours of sleep.
Like on Mom Brain.
Yeah.
Now, going back to milestones, so one of my go-to websites, even for kids, and although I realize I haven't done it in like a long time, which just shows you that it is my 4th child, is the weekly milestones. So there you can do like babycenter.com, all these different things. You can say, okay, this week they should be looking back at you. This week they should be rolling over. This week they should be doing this and that.
Right.
How early can we see signs of ADHD? And I mean, I know that you said that you were cautious to diagnose early because it's toddler behavior. And then I mean, do you feel comfortable at speaking to autism?
Sure. So I'll start with ADHD. You can see signs of ADHD early. The thing is, you may wait for a while for confirmation. Right. So you may see a kid who, for one reason or another, is moving very, very quickly around, say, their preschool or daycare classroom. So it might give you some sense that these symptoms could be there. But there's a large percentage of kids who, over the course of the early part of childhood, may normalize a little bit more. Like there's also research, for example, on the diagnosis of kids with ADHD when they're in the oldest birth month for their grade and the youngest birth month for their grade. And there's some research showing that there's a much higher diagnosis rate for the kids who are on the younger end of the spectrum because they look more immature, which is then something that clinicians should consider. Like, where is your child in relation to the age of the other kids in the grade?
Interesting.
And, those are factors that we always want to consider. And the reason why that research, has heft behind it is because, especially at younger ages, there can be huge differences between the kids who are, 12 months apart in a 4-year-old class.
Right.
That's something we want to kind of pay attention to. With autism, I mean, it's similar in the sense that autism is highly genetically loaded as well. So you can see, signs of autism, I would say more significantly early on in development.
Mhm.
In the sense that because autism is related to a number of social and communicative deficits, for kids in particular who are significantly on the autism spectrum, you may see from a very early age that they don't have a range of facial expressions, that they don't engage in back and forth exchanges, that they tend to have interests in things that are not people related, like they may have interests that go far beyond, like most kids, for example, might be interested in the parts or the moving parts of things. But for a child on the autism spectrum, it may be something where they are far more interested than most kids. They want to
Mhm.
look at every clock for long periods of time, and they get angry and start throwing a tantrum if you bring them away from their passion for clocks,
Mhm.
which gets to like a circumscribed interest. And then they also may have deficits in, say, showing, toys to adult caregivers, or kind of, sharing their experiences with other people in such a way that from a very early age, even around the toddler years, you can be fairly sure that they're falling on the spectrum to some degree.
Mhm.
And for all of these, it strikes me that the earlier you seek treatment or diagnosis, the better off. Is that because the brain is more pliable early on, or what do you make of that?
The thing is, our brains are plastic throughout our entire life. They're still capable of adaptation,
Even
all the
now,
time.
even at
Right.
32.
But there are, of course, massive critical periods in terms of developing certain skills, during life. Like, for example, with emotion regulation, it's thought there's a critical period prior to age 10 in which you're developing kind of that circuitry.
Mm.
So we want to make sure that we're getting intervention to decrease impairment, especially during critical periods of development where everyone else is learning a skill, and we don't want a kid to be distracted from, being able to kind of acquire that skill. Your point about, early intervention, every study will show you that if you have a clinical disorder, the earlier you get it treated, the better off you're going to be. Untreated ADHD, for example, has consequences in literature of, increased number of traffic accidents, increased chance for substance abuse, increased number of tumultuous personal relationships, divorces and breakups, all kinds of developmental
Yeah.
effects, where if you're not aware of what you're struggling with and you're not aware of how to support yourself or get others to help you in supporting, your mental health, there can be lots of negative consequences for
Mm.
life. We just want people to get treatment up front.
Cool.
Oh, good.
And where can people find you, follow you, learn more about you?
It's a good question. Psychologists notoriously do not have large social media presences.
But
Partly,
you should be so good at connecting
I
with people.
Well, the thing
right?
is,
Isn't this your goal?
you're told from early on in your graduate training that the idea is for your patients to be able to access you, through professional means, and that it actually undermines your professional effectiveness if,
It's a
Right.
changing world, my
Agreed.
friend.
So I am actually just creating a Twitter account. I think tomorrow is when I'm creating
Wow.
it.
And
Oh,
what's
wow.
well, do we know what it's going to be so
It'll
that
have
we can
some
follow you?
iteration of like Dr. Dave Child Mind, and it'll be linked to our Child Mind Insta and Twitter.
Okay.
Excellent.
That
So
kind of stuff.
everybody search for that.
Right,
because
So
exactly.
childmind.org for now, though.
childmind.org.
Right.
Okay.